Greetings, cherished members and colleagues of the Academy of Orthopedic Physical Therapy's mighty Imaging Special Interest Group. I'm Bruno Steiner. I'm the current president of the Imaging SIG. Thanks so much for taking time from your crazy schedules to join us tonight at our 2023 pre-Thanksgiving membership meeting. In recognition of our alignment with the actualization of the Vision 2020 Statement on Physical Therapy Primary Practice, we've invited our entire fantastic AOPT membership to participate. I want to acknowledge our wonderful colleagues at the Federal Academy's Primary Care SIG. A special shout out to our dear friend, Primary Care SIG President, Dr. Katie Albright, who collaborated with us to spread this important testimony from a very special guest, Dr. Scott Rezak from the Colorado, who's going to get granular about what it's like to refer for diagnostic imaging as a physical therapist in the Centennial State, where imaging referral privileges, including MRIs, have been accorded by the Colorado Physical Therapy Licensing Board. Needless to say, the Colorado board decision leveraged the talents and skill sets of the primary care physical therapist long envisioned in the APTA's Vision 2020 statement. And tonight he's going to demystify physical therapist-directed imaging referral, and he's going to speak to the uniquely added value that our beloved profession brings to the table when involved in the imaging referral process. And yes, he has been doing this for years, and the sky has not fallen in Colorado. In fact, the skies are all clear for physical therapists towards realizing APT for the primary care physical therapist. But of course, I would be remiss if we didn't get through a little business and a quick look at our nationwide scorecard review, as is customary. So mark it in your calendars, already in the works next month, coming December 18th. We are so very fortunate, frankly privileged, to have former Imaging SIG President Dr. Chuck Hazel and former AOPT President Dr. Bill Boysenald, who are going to give us a substantial first look at their recently completed research. And I got to tell you, it feels pretty amazing to have the bragging rights of seeing the data first. We are promised some exciting results as they present DPT imaging education. Will graduates be prepared for today and tomorrow's practice? Ominous. I'm going to weigh in on this. Of course they'll be. Physical therapy is the only allied healthcare profession that emphasizes musculoskeletal imaging in our education, and our academicians obsessively keep us trying to up their game unlike in any other discipline. On top of that, there's so many opportunities to smooth out the edges if you want to brush up on your imaging stuff. So there. Anywho, can't wait to hear from Chuck and Bill. They're great, and see if you can join us. In January, January 11th, 2024. Oh, you got to silence your phones, guys, or mute yourselves if you're going to carry on extra conversations. In January, I'm really excited about locking in Dr. Scott Brown, who's going to also present some remarkable and encouraging data that speaks to the efficacy of PT-directed imaging in North Dakota. And I'll say it again, the Academy of Orthopedic Physical Therapy brass has decided that we're going to return to our annual in-person Imaging SIG meeting at the APTA Combined Sections Meeting 2024 in Boston. CSM 2024 is just around the corner, and the road show is going to rumble into the cradle of liberty. I look forward to rubbing elbows with our Bay State colleagues and hearing what they have to share about their professional aspirations. So again, mark it in your calendar. The Imaging SIG meeting will happen on Saturday, February 15th from 1:30 p.m. to 2:30. I'm excited to chat with all of you in person and look forward to seeing you there. So where are we with imaging referral privileges? Let's look at the scorecard. So this is what we got. So all in green with an additional Iowa, and I do believe Dr. Corey Zimney's in the house, who fetched us victory in Iowa. Deep greens show us that we can refer for every imaging modality. He did it the tough way, the legislative route. In the light green, you have radiography referral permitted and not MRI. And this is bewildering to all of us because, you know, people are okay with us referring for ionizing radiation, but somehow they can't make the step to MRI. It's a real face palmer. Encouragingly, everything in gray is silent. These are silent practice acts, and this will mean so much to our talk tonight. Inexplicably in red, you have legislation against physical therapists referring for imaging, a real setback, frankly, and a return to the caves and the dark ages. It's just mind-blowing that that we have to go the legislative route in this area to get any change. The military branches have no such limits and have proven the efficacy of PT-directed imaging referrals since the 1970s, and this is what we want to emulate for all states and the Center of Medicare Services. So there are paths to the PT-directed imaging referral. The one way, the easiest way, is exercising the lack of prohibition, i.e. if you're in a silent state, and just don't refer a patient to CMS because your radiologist won't actually be able to bill for the services or actually get reimbursed for the services because we're not on the list of providers. That's something we want to change. But this is the easiest approach. The second approach is eliciting a favorable state board ruling using proper questions for the state board. And this really requires a thoughtful presentation. You really have to be careful about how you approach your state board. These are busy people, so give them context, give them evidence, and consult with us at the AOPT, Imaging SIG. I beg of you. This is an easy way to shoot yourself in the foot by asking an inappropriate question. So please consult with us. The third is the hardest approach. This is the legislative initiative. It takes max preparation. And this is not a type of thing where you rise to the occasion to meet your challenges. This is sinking to your lowest level of preparation. So you really got to work at this. And please, again, coordinate with us at the AOPT, SIG, ISIG. Don't reinvent the wheel. Chances are we might be able to help you. We will help you, frankly. So what about MUSCUS? This is a hot topic. We have to include it, diagnostic sonography, because it's not just about musculoskeletal evaluation anymore. If you have trouble with the diagnostic word, then use evaluative sonographic imaging. There's no prohibition. So the recommendation is just learn it, do it, and practice to proficiency in your clinical context and as an extension, of course, of your physical exam. And I want you to sit the physician credential exam of the RMSK. We have the institutional support from the American Institute of Ultrasound and Medicine. They are heavyweights as far as an institution. And another heavyweight, Intelios, the Point of Care Ultrasound Academy, and the Alliance for Physician Certification and Advancement. The APC is the one that actually does the physician board exam for the RMSK, and we are in the unique position of being able to actually sit that exam. It's a tough exam, but this is worth it. We really show our mettle. We do well at this exam. Again, if you're insecure and you feel like you've got to approach your board about permissions, please, you have to prepare with us, or you're not going to be prepared for the right type of phrasing and giving them background on what they should know before proceeding with a decision. So now to the main event. Dr. Scott Rezak is a physical therapist in private practice in Colorado. He owns Rezak and Associates Physical Therapy. He's been ordering imaging since 2007 and has lectured at the state and national level on the role of physical therapists using imaging to enhance direct access. And he's co-authored a paper on the same. He is also adjunct faculty for the Regis University DPT residency and fellowship program. And of special note, he exercised the silent act option long before the Colorado Licensing Board officially took a stance to recognize the appropriateness of physical therapists ordering imaging. So that's pretty amazing. And I'm also happy that Scott has brought a special guest and a dear friend of the physical therapy profession. A warm welcome to Sarah Carver, who is the sales account manager with Colorado Springs Imaging. CSI is an imaging center working seamlessly with Dr. Rezak to provide the best expedient delivery of care and imaging for his patients. Sarah is generously sharing her time tonight, and she'll take some questions if you have on payers and administrative matters, anything within her limits. And with that, Scott, I will unshare my deck and hand the reins to you. I want to thank you so much for doing this. I know you're a super busy guy, but I want to restate this without stealing your thunder, Scott. All this work began by you referring for imaging in 2007 in Colorado when the PT practice was silent on imaging. And then the court ruled favorably in 2016. Is that right, Scott?
That's correct.
I'm not wrong. Well, go ahead and share and take it away.
Okay, let me get a share screen. Let me know if everything comes over okay on that side.
Okay, just presenter mode now. Okay,
Yep.
go.
Okay, so hello everyone. My name is Scott Rezak. I practice out here in Colorado. I'm I have an OCS. I've been through the fellowship. As Bruno said, I'm faculty, and I've been a private practice owner since '07. We thought it was the greatest thing as soon as we finally got into private practice and we had it down and we knew how to do everything and we were going to do great. And probably my first month in, I had a patient come in and I was pretty sure they broke their foot. So I was like, okay, we're going to send you to the emergency room. And he wasn't having any of it. He's like, I'm not sitting in a stupid emergency room for 4 hours. I'm like, well, who's your primary? I'll give him a call and we'll get something done. He's like, I don't have a primary. I'm like, do you have a dentist? Do you have anything? I mean, work with me. They had nothing. So I gave him a boot and a pair of crutches, told him to come back the next day. So I went home that night and I started reading through the Practice Act because I was like, well, could I order it? Is there a reason I can't? I was fairly new to Colorado. I'd originally come from California where you're not allowed to do much of anything at the time. And I thought maybe Colorado's a little better. And I read through it and I'm like, well, it didn't say I could. And then I thought about it a little more and I'm like, well, it didn't say I couldn't. At no point did my Practice Act prohibit me from doing that. So I gave it another read through or two. They're dry reading. I do understand that. But it's real important to know what your Practice Act says because this determines where the barriers really are to what you can do. And there were two spots I found. One of them said, it was a weird phraseology of language. It said, if I ordered a test that was unnecessary, I could face disciplinary action. So I thought, well, what if it was necessary? Am I allowed to order it? And then the second portion I found was there's a duty to refer clause, which most practice acts have that says if you can't do a particular test, measure, or intervention, you're legally required to refer it out. So at that point, I'm thinking, I need an x-ray on this patient. I can't take the x-ray. So legally, I'm required to refer it out. And I thought, okay, let's give this a try. So I took one of our script pads that we back then would typically use to order DME, and I faxed it over to one of the freestanding radiology centers. And I sent the patient over. And I got the x-ray, I got the report, and insurance paid for the guy's x-ray. He didn't have to pay for it. And so after that happened, we thought, well, that's kind of cool. And so my wife, who is my other, works in the private practice with me, she started ordering. Then we brought on another therapist and we taught them how to do it. And then the first day came when we had to order something bigger than an x-ray. And it was what appeared to be Achilles rupture. And so I was like, let's do an MRI. And so I ordered it up. And that was the first time I got pushed back. And this was probably a year and a half in of ordering x-rays. So I got some pushback and the front desk said, yeah, the insurance company's not going to pay for it. And I'm like, do you still have them on the phone? And they're like, well, yes, they are. So I get on the phone. I'm like, who all is on here? So I had the radiology center and I had the insurance company. And we were on a little conference call. And they said, basically, we don't know that PT should be ordering MRIs. And so in the meantime, I'm faxing over article paperwork and things showing that, look, it doesn't say I can't. This is the Practice Act. You should be fine. And I've been doing this. And they still pushed. So I thought for a moment and I'm like, okay, here's the deal. This is 5:30 on a Friday afternoon. I'm going to have to send her to the emergency room. It's going to cost you $2,000 to walk in the door, $4,000 for a picture, and who knows how much more before we're finished. What if you just pay the $600 bill? I'm happy, you're happy, and the patient's happy. What do you want to do? And they went and got a supervisor, and after a few minutes of deliberation, they came back. They're like, we can get behind this. And they went ahead and pushed it through. It also got paid. And from that time forward, we've gone with CTs. We've ordered ultrasounds. We've ordered bone scans. Now in Colorado, we're actually ordering laboratory studies under the same hole in the statute. And we continued to do this for some time. And then 2016 rolled around. And the state board had finally acknowledged that PT should be able to order, and they added a rule to our current practice act. That rule basically said we can order anything and everything up to and including MRIs. And it was intentionally worded to be vague in case there were other studies that popped up sometime in the future. Colorado's always been rather forward thinking and trying to get away from saying you can do A, B, C, and D. Because what happens if someone invents E? Well, it's not in the list. So you kind of create it so there's a little bit of wiggle room floating in there. Let me jump from that. Sorry. So this was the change they did. Oh, it was earlier than I thought, 2014, actually. A licensed physical therapist may order or perform with clinical justification any diagnostic image which is within the recognized standard of the practice of PT, including magnetic resonance imaging. So this was just vague enough to give us the authority to get away with a great deal of imaging, which was fantastic. So we continued to order. Sometime around 2016, Wisconsin got the order, the ability to order imaging. And they called Colorado, and they called Colorado State Board, and they talked to the then president, Cameron McDonald. And that trickled down to be a phone call with me later that evening. So that evening, we had the discussion. They were asking me, how many people order, who orders in Colorado, give me a list. We want to know how to do it. So I went on this track to try and find all the people to order, and I couldn't find very many, to be honest with you. I was honestly thought I was Johnny come lately and everyone else had been ordering, but it turns out there was a lot of people who weren't, the vast majority. So at that time, the next discussion point was, well, what are you going to do about it? And I hadn't planned on doing something about it, to be honest, because I thought it'd been done already. So at that point, I decided, I talked to my wife. She was actually our planner for the state conferences here in Colorado. And I said, it's already set for this year, but I'll get something.
Welcome.
Beg pardon?
No, somebody else didn't mute. Sorry.
Okay. So I told her maybe we'll get something set up for next year. Well, as it turns out, she went to a meeting for that group that night, and one of their speakers dropped out. So she graciously volunteered me with about 2 months' notice to speak at conference. So, of course, since it was my wife asking, I agreed. So I was now having to prepare an 8-hour lecture in less than 2 months. But things sort of fell into place very organically. It worked really quite well. The local imaging center showed up on my door like 2 days later, saying they'd heard about this Wisconsin rule, and they were trying to tell PTs in Colorado. They were a little misinformed. They thought it applied to nationwide, but it was not. It was just, that was Wisconsin. And they wanted someone to talk to PTs is to give them some legitimacy to say, yes, you can in fact do this. So I agreed to do those talks if they agreed to give me a radiologist for the day at conference to work with. So that's where I ran into a radiologist, Frank Serkovich, and he became kind of my partner in several of these lecture series throughout Colorado. I did a half dozen or so of those besides state conference, and then like 3 or 4 CSMs. And then I'm also, as a fellow, I do a lot of mentoring. So I started calling my fellows and I'm like, what setting are you in? They're like, private practice. I'm like, do you order imaging? They're like, no. I'm like, why not? They're like, my boss won't let me. I'm like, we're going to fix that. And then you're going to come with me in 2 months and you're going to talk about that. And they're like, are you sure? I'm like, sure, they'll be fine. Trust me, it'll work. Then I called another one at the VA. I'm like, do you order imaging? They're like, they don't let us. I'm like, you're going to fix that. And we're going to talk about that in 2 months. And then I called Imaging Task Force, and they sent down someone who had done a recent study on PTs doing appropriate imaging. And I'm like, would you mind sending him down? We'll pay for the airfare. He'll come down and talk and present his findings. And we ended up with a lovely little series, and a friend of mine from a former military PT, he also came down, and we had a nice little panel discussion and went really, really well. And that started in 2016, and I've done numerous speaking engagements since that time and collaborated on some literature as well. And we've actually, it was a fantastic event. The only thing we ran into is the biggest pushback we got was the PT community.
Uh-huh.
Radiologists, no problem. Nobody had a problem with us. The PTs had the biggest issue with doing it. There was a fear factor. There was a lot of unknowns that they thought would happen. And we're going to go through a few of those right now and discuss them. The first thing everyone told me is they won't let me order, but I had no idea who they were. And they couldn't tell me who they were. I'm like, who's the they that are stopping you? Let me know. And they started giving me some ideas. The first one, they were like, radiologists won't accept our orders. Why would they take them? Okay, that's a valid question. So now that I had a good relationship starting off with this radiology group, I went down there and I talked to a bunch of their rads. And they're fantastic people. And they're very friendly. And they're happy to talk to you. They actually, after talking to them for a bit, they enjoy when we send in an order. They don't look at it like, oh gosh, it's a PT ordering again. Because when we order an image, it's not our first gut shot. Someone doesn't walk in and say, hey, my shoulder hurts. And we're like, let's get an x-ray. We don't do that. We look at the shoulder, we play with it, we decide what's going on. Maybe we need an image. Maybe we don't. But if we do, it's very specific. I want to rule out a Bankart lesion. I would like to rule out a rotator cuff tear, or axillary nerve trauma, whatever. This gives them something very specific to look for. And very importantly, on the front end, it kept me from ordering the wrong things. Because in the early phases, I'd be like, I'd like to order this. Is that correct? They're like, no, that's the wrong thing to order. You should order this. And some of those conversations led to me learning how to use the ACR guidelines online to figure out what really is an appropriate order. And the number of times I've called them, they're happy to answer the phone right away, and they're super helpful with us. I've had nothing but positive experiences. I've never had a negative experience with a radiologist. This was Frank Sirkovich from our very first lecture from back in the day. He also did a CSM with us in Denver. I'm not going to remember which year that was. So the next concern was imaging centers were going to be worried about us. And I don't know where that worrisome came from, because if the radiologists are fine with it, the imaging centers love us. We're an untapped market. I mean, we do order in a way that they enjoy, but there's what, 300,000 PTs in the country? That's an untapped market for radiology. They don't hate us, they love us. They love us dearly, and I'm pretty sure they would like more of us to do this. The problem is we run into what we consider to be barriers when they're really not. Now, here's where things get entertaining. There are clinics. In Colorado, again, is a little bit different from everybody else. We put holes in our practice act so we have a little more room to move and to practice at the height of our scope and to do as much as we are capable of doing for the best benefit of the patient. In Colorado, at least, I don't know how other states operate. If an employer attempts to infringe on my freedom of practice and I allow it to incur, that makes me negligent. Nobody else. Because I surrendered my autonomy if I do that. So if my boss says, don't order imaging, I want you to call the primary to do it. No. What's in the best interest of the patient? The sooner I get this done, the better. Should I wait 2 weeks for them to get an appointment with the primary and another 2 weeks before they get an appointment with imaging? Or is it more appropriate if I order the image today and get it done in 2 days and we get the patient taken care of at a better level? I cannot argue for the other option of a 4-week delay for an x-ray or a suspected AAA or something potentially tragic. So your boss doesn't really have that legal right in the state of Colorado without placing all the negligence on the person who surrenders their scope. It's just like your boss saying you have to do 5 units for every patient. They can't legally do that. That's overutilization. That's not legal. Not in any state as far as I can tell. Same thing, they can't tell you you can't manip if it's legal in your state. If it's within your scope of practice, you are effectively able to do so. A policy cannot impede that. There will be exceptions when you get to things like the VA, because military is its entire own universe. But we did have very good success with that sometime later. The problem with that is the VA doesn't see us as independent practitioners. We're technicians. But the Denver VA now sees us as independent practitioners, because that guy I drugged to that very first imaging place from the VA has made that happen. So it is very much doable. Hospital policy gets fuzzy. It depends on the group. Generally, most hospitals belong across state lines. So what they will do is they will cater to the lowest common denominator. What's the most restrictive rule? And they're going to follow that so nobody gets in trouble, and they'll make a singular policy. You can still fight that at the state level. You are going to have to make conversations. You're going to have hard conversations. You're going to have to go into the hospital, sit down in front of 8 physicians and be like, this needs to happen. This is why. Or more importantly, sit down and ask them, what is the issue with us doing it? What is the barrier? Why not? What do you think is going to happen? What's the worst case scenario? And they will come up with other worst case scenarios for you, I promise. The hospital's biggest one, they were basically afraid if we saw something on an image and it wasn't related to what we were looking for, we would ignore it. So maybe I go look and see, oh, did you crack a rib? Oh no, you've got an ascending aortic aneurysm. Oh, well, at least you didn't break the rib. Let's do a thoracic manip. No, we're not going to do that. It doesn't work that way. We do have to take on a little more responsibility and have a plan for what comes next. But that was their biggest gripe, is that and overutilization. And actually, if you look at it, we underutilize relative to other professions. We take way less imaging. We're way more targeted with our imaging. I believe Aaron did a study where it showed that, if I get the wrong authors on this, I apologize. We were 98% of what radiologists would consider appropriate. And it turned out those 2% is we weren't ordering enough images for when we thought it was a stress fracture. But quite frankly, if I think it's a stress fracture, an x-ray is not going to change my mind on what I'm doing, so I don't see a point in ordering it. So our 2% error was underutilization, not overutilization, and not ordering the wrong thing. And I do have a habit of jumping on bunny trails, so if I meander off everybody, just hold on, I'll get there at some point. Federal payers. Currently still, Medicare has us listed as a no as PTs in private practice. PTs in other settings are still technically allowed to some degree. Has it been utilized or pushed? I don't think so. That might be another area to look. But Medicaid allows it. And if Medicaid is allowing it and TRICARE allows it, at some point, I mean, Medicare right now is the only holdout on the list. And that's just because, similar to the VA, we are not seen as autonomous providers. We need to change that visual from them to us in order to help that. Which, if we could score Medicare, that would be a landslide. We would get that would increase the number of states, I would imagine, quite prolifically.
That's the dream.
Yes, that's where it should go. And nothing was ever said in my practice act that I was good to do this. It just didn't tell me I couldn't do anything. And if there's no prohibition against doing it, technically, if you can justify it medically, it's within your scope. Okay, another one I heard is they were afraid patients were going to get stuck for the bill. And to my knowledge, with the exception of that one argument I had over the ruptured Achilles, since I've been ordering since 2007, not once has a patient ever gotten a bill. I mean, and that's 9 of us, 9 PTs that are in my practice now at this point. We all routinely order when it's necessary for everything from head CTs, contrast, whatnot. We've never had an image backed out cost-wise. I don't know if Sarah's on the line, if she could speak to that at all. If she is and figures it out, she'll jump on and let me know at some point. This one was super entertaining. I had two or three practices here in the Springs that told me they were afraid to step on the toes of their referral sources. They were under the impression that if they ordered the X-ray or the MRI, the CT or whatever, that their referral source might get upset with them. And I thought, well, that sounds kind of like a valid concern. The last thing you really want to do is tick off a referral source, because that generally doesn't go well for you. So I actually called all my referral sources. I get them on the phone. I'm like, hey, John, do you have an issue if I ordered an MRI on your patient, our patient last week? Language choice is important. The patient is not theirs. The patient is ours, mine and theirs. They referred the patient to us. We're both part of the care team. I ordered an image on behalf of our patient. And I sent you a copy of it. I kept you in the loop. You have a copy of the image and the report. It was faxed over day up. Do you have a problem with this at all? Are you cool with that? Do you have an issue? And they were confused. Every one of them. They're like, why would I care? They're like, otherwise, I just have to have you call me. We talk about it. Then you send the patient. I talk about it again. And then I order the image. And then we find out. And then I send it to you. It's like, let's just take out the middleman. Go ahead and order the image whenever you want. It doesn't matter. If you think it's appropriate, you do as you see fit. And I did not find a single referral source that had a problem with it. I had one or two that didn't know we could. They were like, oh, you guys can order it? Well, why am I doing it then? I'm like, I have no idea, but you won't have to do it again as long as I think it's appropriate on this side. And they were okay with it. Again, not a single day of kickback. I still have some practices that are afraid to do it for that reason. A little more old school. They're really reliant on the idea of I need to have my referral sources versus this is Colorado with direct access. We don't need a referral for any insurance here. The exception of one variation of TRICARE has to have a direct referral, and Medicaid has to have something at some point within 90 days. Otherwise, function autonomously. And after I've dispelled all those, again, I went around, I did probably 4, 5, 6 lectures with Colorado Springs Imaging. They put on events all throughout the city and up in Denver. And even after that was dispelled, there was still some kickback because they were afraid because they didn't know how to do it. They were like, they're like, great, I can order imaging. What am I supposed to do and when and how and what? And they found that a very large barrier. And I could see it's a new skill set. So it's a little intimidating to have to do something different. But it's really not that big of a deal. It's really not. If you want to order an image, you can go onto the ACR guidelines and it will literally walk you through. There's two categories. Either you're a member and you can log in, which is not us, or guest log in. And you can literally walk through they have like a whole criteria section. They break it to musculoskeletal, neurologic, cardiovascular, OBG, and work your way through and find what you're looking for. And it will not only tell you this is what you should order, but it will then say, this is the evidence for why you should order this. And it will break it all down for you. And this is the rating of how appropriate this image is. And this is how much radiation you're looking for if you do this. And it writes it all down for you. And quite frankly, if you're having a hard time even navigating that, just call them. Call them up, say, I have a patient with ABC. What should I be ordering and why? And they'll tell you. Order it. And the best thing about it is, I'll assume that there'll be a decent show of hands. How many of you really hate to get those little discs and then have to figure out how to get them to open up in your computer? I can't, it drives me nuts. Absolutely drives me nuts. And how many of you have a computer that even has a place to put the disc anymore? Most of them don't even have it. You have to get a second piece and plug it in the side. And then that takes 20 minutes to get that through. I used to give that to my front desk. He'd be like, let me know when you have a picture up. But the vast majority of them now give us a login. If my patient says, yes, I had imaging at Colorado Springs Imaging this morning. Okay, cool, hold on. I can go in, log into their system, pull up the patient's imaging, I have the report and I have the pictures. And if I decide I need another image, I can hit a button and I can order another image right through the computer screen. And it's electronically ordered. I get an email when they're scheduled. I get an email once the image is available, and then I get an email when the report's been rendered. It's really pretty turnkey. It's much easier than I ever thought it would be. Outside of a few arguments with insurance companies way back in 07, early 08, have not run into an issue in a great deal of time. So the value of this. So it's cool. It's kind of fun. We get to order images. We have to, there's some responsibility with it, of course, and we'll cover that as well. But this makes direct access absolutely amazing. You get to skip a lot of extra steps that aren't necessary with this. And if you have something acute, this is Colorado. People run, ski, bike, hike. They jump out of stuff, jump onto stuff, get run over by elk. I mean, we get some crazy stuff out here. I literally had a patient who got ran over by elk last week. They should not have been trying to get a selfie, granted, but yeah, stuff happens. But now we can pull them in and get them seen right away. And a barrier to full direct access, because currently we have technically some form of direct access in all 50 states, but some of it is very restricted. And one of the arguments is, why should we give you direct access if you can't even order an X-ray? Well, what if we could all order again? If we can get to where we could all order, that would open up that direct access. Colorado's direct access is very, very open. There's virtually no limitations on it, to be honest with you. So the imaging component is actually quite helpful. We can get patients in, get things moving, get answers much quicker than we ever could before. If you think there's something more deleterious, you don't have to wait 2 weeks to get imaging done to see what's happening. You order at that visit with the patient. And boy, if you're trying to get buy-in with a patient who's just fed up with the medical system, and they go see their PT and they can get their imaging done, get everything taken care of, one-stop shop, and everything's going well, they love this. It works really, really well. The ability to avoid potentially catastrophic events. I have a few case studies on here going. If we get that far, I'll discuss them. But this has come in handy on more than one occasion. We've caught brain bleeds. We've caught aortic aneurysms that came in. You get those patients coming in when you think it's a AAA, trying to ship them to the ER during COVID. They won't go near the hospital for love or money. They'll go to a freestanding imaging center though. And then once they find out it's something serious, you can redirect them then. Quality of care alone, just the sheer timelines. Right now, if you go see your provider, especially post-COVID, the amount of time between when you get in and when you get your first lab test and your next piece, it's so drawn out at this point. And what do we know about the longer a condition is left untreated? The chronicity of it becomes a chronic pain issue. We start getting centralization. We start now, something that should have been a sprained ankle is now a Crips patient. And things are now much more complex as patients now got a percentage of time they're going to be there longer. We can get them in and get things moving in a much more timely event. Continuity of care. They're still with you. You're the one who pulled them in. You're the one who ordered the image. You're rendering the care. They're in one place. They feel comfortable. They're not being bounced back to another provider who then gets an image. And because of the image, now they're seeing orthopedics. And then they're going to get medication and some injections. And we've seen the effects of when you start down that road, and just the sheer cost of it as well becomes out of control. This is probably the best. the being able to correlate your symptoms quicker if you need to, and to correlate and to collaborate with other providers. The imaging helps a great deal, because there will be some providers that without an image, like some of the primaries out here and some of the orthopods, if they don't have a picture to look at, they're not going to want to have a discussion about what's best for this patient. So if I call them and be like, I have your patient here, here's the imaging, it's sitting on your fax machine, by the way, and I need to chat with you about them. and they'll go pull the imaging. They have access the same, and they'll look at the pictures. We can have a conversation right there in real time and make decisions based on what's best for the patient, and not have it 2 weeks, 3 weeks, 4 weeks, 5 weeks out. If there's an osseous compromise, we know by 4 to 6 weeks, it better have landed in the right spot, or we're looking at it having to be rebroken. How is that a good outcome? That just sounds rough. I wouldn't go to that appointment. Come in Tuesday, we're going to break your arm. No, sounds not good at all. And the downside-ish is more responsibility. When you see that unusual mass that the radiologist points out and says, further workup is required. Okay, where am I going to go with this? I have to have some sort of a plan going forward on that. Because I ordered it, I have to do something with that picture. I can't just turf it off. And in some cases, many cases, patients in Colorado don't have a primary care physician. They'll have a PT, for example. And it's all on you. If you see a weird mass, what do you think? Internal medicine, oncology? At this point, now that you've made such lovely collaborations between radiology, you've talked to orthopedics, you've been talking to primaries, call them up and say, hey, this is what I'm seeing, what's going on? Who do you recommend that you like for something like this? And you'll start to develop this really nice roster of, these are the oncologists I like, these are the internists that are really good, these are the DOs I'm working with right now. And you know who could see what. So when you get those aberrant findings on an imaging study, you can send them to where they need to go. So appropriate use of imaging. This is where things got a little weird on the front end. Once people were realized they could order, some people got a little trigger happy on it. But with enough extra imaging discussions, talks, and lectures, that got better. The whole goal of doing this is we want to help the patients without overutilizing. We are being watched. And this is not necessarily a bad thing. Everyone gets nervous. Oh my gosh, they're watching us. Good. Show them what you can do. Show them you can do this correctly. Let them watch. And if we do something out of line, they're watching, they'll let us know. This is a good thing. This is not a punitive thing in any sense of the word. They're watching, they're just curious. This was unprecedented territory. PT's ordering imaging was weird, and so they were keeping an eye on it. They wanted to make sure we didn't get too weird about it or overutilize it. The two big things to keep in mind is who benefits from this image, which is the hugest one. Why are you really doing this? And is it going to change what I'm going to do? If taking an image isn't going to make any difference to what you're doing, then why are you doing the image? What are you hoping to accomplish? The only person that really needs to benefit from this is the patient. I've heard some people ask about confirmation imaging. That's a terrible idea in my mind. And I'll give you a reason why. If you think it's an L4-5 disc and there's a compression, a lumbar radiculopathy, and you've confirmed it with myotomal, dermatomal compromise, and directional testing, why do you need the MRI? What possible reason would you need that for at that level? Now, if you're treating it and it's not getting better and it's not reacting correctly, now you've got a good argument. Something weird is something's amok and you need a better look at it. But just to confirm what you already know, don't go there. There's no reason for it. And you're driving up the cost of healthcare for no good reason. And you don't want to be the reason that healthcare gets more expensive. We tend to be very good at ordering and keep the healthcare costs down. That trend needs to stay in place. Now, there is some argument for establishing a baseline, or at least in my mind. I could be incorrect. Someone's sure to disagree with me, and I'm happy to have that discussion. As a primary care, or as direct access providers here in Colorado, we will get patients with conditions that are typically, as a new grad, you would consider a red flag. So like cervical myelopathy, someone comes in, maybe they've had it for 2 years and it's not progressive, and it's been there and it's not changed. if something happens in the future and it gets weird, I'd like to know what changed. Was it just an exacerbation, neurodynamics? Are we looking at a centralization commitment situation, something else going on? I might pull an image to have a baseline to compare to later if there wasn't one already done. But under those circumstances, then I would have to decide if I wanted to refer them off to a surgical consult. Technically, I should and I would, but I would call the surgeon first and be like, this, I'm referring them over because this is what's appropriate to do. I see something on here that's outside my scope to treat. Well, surgically to treat. I'm treating them conservatively. They're staying under my care. But the reason I don't think they need surgery, when you look at the image, is their clinical presentation is they have not had any change in 2 years. And they're just tired of it and they'd like it to get better. It is non-progressive. And conservative care is shown to be a better outcome than surgical if it's a non-progressive myelopathy. So the patient doesn't want surgery. I don't want the patient to have surgery. Are you on board with this? Would you like to see him and examine him? Do you want to have an appointment and talk to him? Have that conversation. And normally they're very happy with it. Again, I've not had a single one of those conversations that went sideways. Sometimes 3 or 4 times throughout it, they're like, so you're the PT that ordered this, right? You sure? And you have to clarify for them, and then they're okay with it, but afterwards everything seems to be going just fine. Beware the therapeutic image. I see this ordered on occasion. I don't like it. Just because my clinic in particular sees a lot of chronic pain. If you take an X-ray, CT, or an MRI of a 60-year-old person, male, female, whatever, you're going to see some age-related artifact. You're going to see some degeneration. You're going to see some facet issues. You're going to see things on there. And unfortunately, the patient nowadays gets access to their reports as well. Normally not for a few days till after we do, so we have a chance to diffuse it. But if you have someone that's high levels of anxiety, fear avoidance behaviors, and they see something like degenerative disc disease, boy, they're going to spiral out of control. It's going to be a mess. You might be ordering that to show them that, look, you didn't break anything, but they have degenerative joint disease. They're going to go off on a tangent. Therapeutic image to show them there's nothing wrong is very risky because artifact is present in most people to some degree. You just want to be very, very judicious with the use of that sort of image. So bottom line, if you're not sure if you should order an image or not, ask some basic rationalization questions for it. Most important, is this image going to assist in ruling out a deleterious or potentially a catastrophic pathology? If the answer is no, it may not be appropriate to order. If it's a yes, absolutely you should. Is this going to alter my plan of care? If it's not going to change your plan of care, I would be very hard pressed to know why you're ordering the image. And we have to be cautious not to fall prey to what we've done. Physical therapy back in the 80s did this a lot. Patients would come in and be like, I really want ultrasound, and we'd give in and do it. No. If they come in, they're like, I want an MRI. Well, let's see if one's necessary first. Well, I want one. Well, you may not need one. Let's find out first. Let's look at this together and walk them through it and talk them through it. It will almost always end up just fine. I've never had one that went terrible in that scenario. But if it's not going to change what I'm doing, I have to really wonder what the image is. If the image isn't going to change it, it's probably not valid to have. Let's not, excuse me. Let's not negate X-ray exposure. We can, X-rays, not a ton, but there is some. CTs, substantially more radiation. Is the radiation you're putting that patient through worth the data you will collect from ordering the image? If you're not sure, you might not want to order it. You might want to go back and ask that first question. Is it really ruling out or ruling in something I absolutely have to know? And is there evidence to support it? There's really not a lot of evidence for PTs ordering imaging yet. It's building and it's getting better. The Ortho SIG here has some of the best setup for that I've seen. They've got everything down. It's getting better, but the more we do, the more imaging we're going to create for this. And keep in mind all of the three pillars. It's not just clinical evidence. What does your expertise say? Do you have an idea of already what's going on, and do you need that picture to justify it? Team treatments, we always talk about intercollaborative, and then I talk to PTs who have never had a conversation with a physician, a radiologist, a podiatrist, or anyone outside of their bubble of the clinic. We have to get outside of this if we're really going to be direct access and primary care providers. We have to do that. We can't grow if we're afraid to make that jump. Don't be worried about that phone call. Call the radiologist. Disagree with the orthopod. Disagree with the neurologist. You're going to have those conversations. Go ahead and stand up to your boss, because that's what's needed to do to advocate for your patient. Get onto the state board, and so you can get in there and make those arguments. Go to House of Delegates so you can have that discussion that when they said we should be doing radiology, you should be on the floor talking about it, saying, yes, we should. We all have to get involved. We can't just wait for it to happen, and we have to be willing to do the hard parts. Some really good resources available. There's some through APTA Learning Center. This is not exhaustive by any means. There's so much more going now. Imaging SIG, Imaging Task Force, they have a lot, and they are constantly developing more. Bruno will be able to speak more to that. There's a lot of education groups, MedBridge, EIM. I recommend on the weekends, if you're bored, like really bored, go play around with the ACR guidelines. It's really impressive the amount of data that's on there and how much you can learn. I mean, show of hands, how many people still want to see an open mouth x-ray? Open mouth x-rays are still common. What do we teach in school? Open mouth x-ray, right? Open mouth x-ray is a 53% sensitivity to rule out a potentially deadly fracture. That's a coin toss. Literally flip a quarter, you got the same chance of guessing right or wrong. And there was I don't remember the name of the author on that, but there was a study done on it. It was probably 80 patients, and there were several really bad mortality type episodes with it. It should be a thin slice CT, which is rated 9 out of 10 for the evidence on the ACR guidelines. And an x-ray open mouth is rated a 1 out of 10. So it's the least useful image for us. It might be effective if they had a massive crush fracture that you couldn't miss. But really, a thin slice CT to make sure that DENS is intact and has not suffered any trauma is the gold standard for that. If you send them to the emergency room for suspected upper cervical spine trauma, they will get a thin slice CT, unless you send them with an order that says x-ray open mouth. Now, a nice little quirk is if you're ever unsure and you don't have time to make a phone call, like in that situation, right on the order, radiologist discretion, rule out upper cervical trauma. And then the radiologist has the right to choose whatever image they think is best. And then when it's done and the whole episode's over, call them back and ask them what happened and why. It's a great learning opportunity. Radiologist has literally been my favorite thing from the beginning. Now, one thing we do run into is we think, like the number of open mouth x-rays I've ordered, way more than I should have, until I figured out how to do it right. But in the beginning, I really thought I had this going, kind of like when you first graduate PT school and we think we know it all. And then 2 years in, we realize we don't know a whole heck of a lot. And then we slowly build back up where we were. It was the same thing with imaging. We just had to recognize it's a new skill for us, and there's going to be a learning curve. And we might think we know the right answer all the time, but make a good relationship. Sometimes I'll still order an image and I'll get a phone call. Hey, Scott, maybe let's do this instead for this reason. I think this would be a better image for these reasons. Fantastic. Please make it happen. Thank you for calling me and letting me know. The radiologists are great about staying in contact with us. I talk to at least one radiologist at least once a week, sometimes more than that. I have a guy that orders probably 4 times a week. We see a lot of head concussion and head trauma. They're always trying to figure out a different way to take an image. And there's a lot of collaboration going on with that. How are we doing on time, Bruno? Can I run through a case study or two?
I would love it. Just go ahead. If people have to leave, we understand, but we are recording this, so these are pearls. So go ahead.
Okay. So this patient was a 31-year-old female, new to the state, who had no established primary care. Was in a rear impact motor vehicle collision, launched to a second vehicle. I believe the original impact was roughly 70 miles per hour. They were a healthcare provider. I believe they were an RN, BSN, I don't remember, to be honest. This one was some time ago. And called their insurance company, said, what do I do? They were referred as a first measure to pain management, which made my head spin. There was not even an ER visit for this. So pain management, injections, until the neck pain was gone. And then they decided to address the low back pain. And the patient was like, I'm really not a fan of medications, injections, and so forth. Can I do something conservative? And they're like, we'll send you to physical therapy, but it probably won't help. Thanks for the vote of confidence. So off we go to physical therapy. They show up. And during the evaluation, when I have patients who are post MVC, I tend to move around a little bit more because I want to see how they naturally move. I don't necessarily tell patients, turn your head, move here, move there, because then they never move right. It's like looking at someone's golf swing. If I look at your practice swing, it doesn't tell me anything about your actual swing. So I kind of move around a little bit to see how they naturally move. And this person wouldn't turn left, like ever. And so when I asked about it, they reported that turning left or shaving their armpit made them go dizzy and sometimes blind. I found this a smidge of it, a little bit alarming. So put her in a C-collar, sent her off for a CT, thin slice. I originally tried to send her to the emergency room, and she's like, no, I'm not going. They're going to do medications, they're going to do drugs, injections, I won't go. I'm like, urgent care. She's like, no. I'm like, okay, freestanding imaging. She's like, deal. So sent her off to there. So I sent her off, and I get a call back, and they say the image is fine. And I was really surprised by that, because I'm like, are you sure? Because she had all the symptoms of a VBI. When she turned left, she was diaphoretic, pupillary dilation, had difficulty speaking, slurred speech, everything. They double checked it. It was fine. There was a little abnormality in one of the lateral foramen of the lower cervical spine, but it appeared congenital, not acute. I'll jump to here real quick. This was the studies, Holmes, and I can never pronounce the last name there. That was the one that looked at the sensitivity for C-spine fracture, and that CT thin slice was 98% good at ruling that out. So that's when I figured out that was what I should have been ordering all that time. Radiology, 52%, or radiography. And it was math in 2007 that also stood that up. It turned out that patient actually had a different pathology. Turned out it was a subclavian steel, which is common with TOS type symptoms. So we then had her raise an arm in the air, and then she also had the same sort of VBI symptoms. So it turned out that one was not as deleterious as it could have been. However, had we sent her to ED or orthopedics and neurology, the likelihood of a fusion or a stenting would have been very high, based on just what they saw from the symptomology. Is everyone familiar with the Canadian C-spine rules? I would assume, to some degree. Yeah, she was very, very positive for all of those. She eventually successfully was fully treated and released back with no restrictions. Second individual is where we had to have a disagreement with some of the findings. A patient came in, 16-year-old runner, was running baton, and as he took the baton, he felt 2 pops in his leg, up in the hip groin area, and face planted. Needed help to get up. After that, hobbled off the field, but a couple days later was up and running, saw his primary care, and was cleared to go back to sport if he sees his PT first for some conditioning. So he was sent to me for conditioning. He was 2 weeks post-injury, had very focal point tender pain on ASIS and AIIS on the front, and only had pain at this point with active hip flexion. Now, bear in mind, again, 16-year-old male, so they've got still soft bones. I've seen pediatric patients run on fractures. And so I just thought I wasn't happy with the presentation, sent him out for an x-ray. X-ray came back, said nothing's wrong, no fractures, you're just fine. I couldn't let it rest, saw the patient in the next day, looked at it again, called the radiology department and said, I'm positive something's going on here, but it's just not showing up on the x-ray. And I had a great conversation with the radiologist. Apparently after talking to him, they were like, well, there's a certain type of MRI that would look for an avulsion fracture that's non-displaced in this type of pediatric population. I'm like, can you run that, please? And they're like, absolutely. And it came back as, oh, where'd it go? Both of those had an active avulsion fracture. Now, at this point, we're now 4 weeks in. So I send him over to orthopedics. I don't discharge the patient when this happens. They're still my patient, and I'm now referring them to orthopedics for assistance. But I'm not DCing them to orthopedics. I'm keeping them, they're mine. I'm responsible for this person's care. I did the image, I'm their primary in this situation. So I need to keep them on my schedule. I don't have the luxury of letting them go at this phase. So I send them to orthopedics. I get a phone call from orthopedics. We have a discussion about how all of this came about. And they're like, well, it looks like it's fairly stable. We took a second image. It looks like it's pretty good where it's at now. Be gingerly for 2 weeks. And after that, you can do what you like, but you keep seeing this PT, you guys are doing fine. And we continued on, and we've had a great relationship with that orthopod ever since. This is one of those ancillary those extra findings you get that are a little more intense than you expected. I'd seen this gentleman off and on over the years for low back pain, multiple lumbar fusions, multiple cervical fusions, 81 years old. Back pain was very stenotic in the way it was presenting, even after the years of fusions. And he came in one day and he's like, my back pain it's different and it's worse. I'm like, tell me about it. He's like, it's kind of more on my side. And I'm like, well, you want to sit down, lie down and talk to me so you're not in so much pain? He's like, no, it's way worse when I lie down. So that puts a flag in my head. That's not a good sign. He's got the BMI for it. He's got the build for it. So I get out the stethoscope. He's got the breweries to go with it, but they're higher than I expect. So I'm suspecting like an ascending aortic aneurysm. So I tell him, you're going to the emergency room. And he's like, no, I'm not going there. COVID's still going. I'm not going near it. I'm like, the urgent care. And he's like, no, not happening either. So I sent him to the local imaging center. And over the time, I've learned more and more about when I order images, what you can do. And so what I ordered the CT for it. I put rule out aneurysm, and I put on there radiologist's discretion because I didn't want to have time for a conversation. If you think it should be something else, please pick. And then I wrote down hold and call. And what that tells them is take the image. You don't let the patient leave. Once you have it read, you call me, and then I'll let you know the disposition of the patient, what to do with them. So he went down, he got the image, they kept him in the lobby. They called me back and they're like, yes, he has a ascending aneurysm. It's a little too small to be surgical, but there's a mass on the pancreas as well. And I'm like, well, good news, he's not going to die from the aneurysm, but what's the mass? And they're like, we don't know. You're going to have to follow up with it. So I called an internist I knew, explained the situation. It turned out it was a very early cancerous tumor. It was benign at this stage, and they were able to get that out in time. And that did not end up being a problem for him anytime in the future. And the aneurysm, I referred him to cardiology, and it was a stat referral. So they took him 2 days later and they monitored it for about 7 years until he passed of a completely unrelated event. But that was an unanticipated finding. I wasn't anticipating what to do with that, but had to plan for it. He did have a history of tobacco use, the flank pain, pain supine, overstanding. Those are really some of those cardinal signs you see for someone coming in with an aneurysm. You got to move quick on those. And sometimes I'll even have my own people in the early stages would come to me. They're like, I think this is happening and I want to order, but I don't want to be wrong. I'm like, I would rather you order and be wrong than not order and be wrong. The worst case scenario, they have a trip over and they get a nice picture taken. You feel bad about ordering something where you might be wrong and the patient dies. Where do you want to go? Order the image. The world was not going to end. I've ordered wrong images. Nobody gets mad. Nobody gets upset. Nobody scolds me. I might get a phone call saying we should order this instead. Great, learning curve. Don't take it personal. I already talked through all of that because I talk really fast. Okay. So really, it's much easier than you would think, and it's not nearly as intimidating as it has to be. And nobody doesn't want us to do it. Everyone's fine with it. And it can only enhance your practice. It can only really solidify that connection you have with the patient when you can take care of a lot of different things for them and keep them out of that whole big medical model where they're stuck waiting 2, 3, 4, 5, 6 weeks for appointments here and there and having to suffer through injuries and pain in between. It allows us to really get to what the crux of the problem is much faster. It's just another diagnostic tool for us, but it's one that lets us get past some of those scary things that would normally make us have to pause for several weeks at a time. Or when you refer the patient out, they get referred for the image, then they get bounced to orthopedics, and then you never see them, and suddenly they show up post-surgical for something they may not have necessarily needed 6 months later. And in the end, that benefits the patient.
Fabulous, Scott. This my head's swimming with questions, and
Fire away.
I really I echo. I mean, there's so much to unpack here, and I can only agree with everything actually. A couple of points that I want to mention in terms of your cases, which were just amazing, and thank you for all those clinical referrals. And that's what I want to impress upon everybody. Every conversation you have with a radiologist, and these are nice people, they're just dying to talk to a human, frankly. And I know, Aaron, we've talked about that before. They're really actually friendly. Once you get beyond maybe some management that really doesn't know how to deal with the physical therapist ordering images. But really, any conversation with these people, it's an opportunity. And as far as the responsibility, the added responsibility, well, this responsibility gives us professional gravitas. It's really impactful. It has been for me and others as well. I wanted to talk about. Oh, gosh, there's so much here. You mentioned that the only obstacle seems to be ourselves.
Yes.
And that's what I've noticed. We're always looking for a reason why we shouldn't. There's never the right moment. We need to be more prepared. Yet, there's really no other profession, allied health profession, that's more prepared than we are. And when I first ordered imaging, and I remember ordering some image for a suspected stress fracture, really bad one, intra-articular one across the knee. I said, this thing is just kind of awful looking. And then I got a call back from the radiology center, and they basically called and said, yeah, you left the diagnosis off. I said, oops, sorry, my bad. And another thing where, our 3 Tesla coil MRI is off. We only have the 1 Tesla, and I don't want to do that to you. And so we're going to send you to another place. Is that all right? Oh, so you have 3 Teslas off? Yeah, sure. I appreciate that. Who do you recommend? I mean, there's no primary care physician, NP or PA that's going to know the difference. But this is just they're helpful. They will help you along with it
Very.
to make your initial errors. There's a community behind this. You're not there to prove yourself. It's not an adversarial relationship. And here's the funny thing. So physicians, this is literally this is Seattle Radiology. They had a cheat sheet of imaging, and it was a simplified multi-sheet tool that was PDF on their site, because they know not everybody knows how to image refer. I mean, they have this. They just literally, you have training wheels given to all kinds of physicians who order. So it's just, they do make it easy for people, because they really don't expect everybody to know everything. So I just wanted to express that. Um, Aaron, you must have a question for this. Must have resonated for you.
Not a question, just Scott, you're my hero. Really, we're kind of cut from the same cloth, I think, and I just wanted to say your style, your delivery is so engaging, and keep telling your
Thank you.
story, man. Just keep doing it. Um, I think what can resonate with a lot of folks is the very practical nature of what you're talking about. When your practice act is silent, as Bruno shared, at the opening of the meeting, that's good. That's a whole lot better than it being red or negative. And we have an onus of responsibility to do right for our patient, and I think we forget that sometimes. You know, if at the end of the day you can say with confidence, the reason I'm making this decision to order this X-ray or CT or whatever is because I believe it's in the best interest of the patient. You can lay your head on your pillow at night and you're going to be fine. You're going to be okay. Just keep it at that level. And I think most therapists understand that I'm doing this for them, not for me, not for my practice. I'm doing it for them. And if that stays the goal, we're going to be okay.
Yeah.
Thank you for the story, Scott. I really appreciate it. Great job today.
Thank you, Aaron. One thing I would recommend anyone who's not sure about ordering yet, or if you're in a state where you think you can do it, call a freestanding radiology center in your area, because they will come to your clinic. They will bring you prescription pads. They will tell you what you need to do. They will walk you through the process. They'll give you logins. They want to be there and they want to help. Give them a call. They'll do it. We keep a really good relationship with all of our radiology centers. CSI and we chat on a regular. He's been by the office numerous times. It's just a really good collaborative. There's nothing to be afraid of. Ask them for help, and they will be more than happy to do so.
Scott, in the chat, there's a question from Catherine.
Okay, one thing I do want to caution, not just your practice act, but look at the Rad Tech's practice act. Sometimes there's a restriction on who they can accept from, and then that has to be changed. But if they don't have a restriction on who they can accept from, then there's really nothing left as a barrier.
But there's one thing technically on that, Scott. So we've encountered that problem, and I was wondering, I thought, okay, so yes, this is not a cool thing, but there's kind of a so what component to it. I want to refer to the radiologist.
That's true.
And so I talked to Louisiana about it, and they're really, really interested in acknowledging I don't call it an expanded scope of practice, but really investigating what they can do. And they really want imaging referral. And I said, so are you concerned about your radiology tech thing? Because they have such a thing. I said, we couldn't care less. We're not acknowledging them as the radiologists. They're not radiologists. So, I kind of push back. I used to not push back on that argument, but I've pushed back ever since and going like, wait a second. We're not beholden to them. We're not referring to them. We're referring to the radiologist. So I think we have to rethink that and give that a hard push. What do you think?
I think that's a great idea. Yeah, no, that's a very good rationale. We really want to talk to the radiologists and know that's where the order's going. So where it comes from, that makes sense. I would push that hard.
Right.
I
What's
never
Cath-
thought of it in that angle. That was an excellent thought, Bruno.
yeah. Okay. What's Catherine's question, George?
Yeah, she just says if the wrong image is ordered, could this be framed as an unnecessary image and run into trouble with the state?
Oh my God. Oh no, indeed.
So the question, so let me, if I heard that correctly, they're worried if they take the incorrect image, could they be face disciplinary action?
That's what it sounds like. Yeah.
I've never, I've told, like I said, I've ordered the wrong image on occasion. Physicians order the wrong images. PAs order the wrong images.
All
None
the
of us,
time.
all the time. We do it less than most. So if you happen to get it wrong once in a while, it is not the end of the world. Nobody cares as long as you have a decent rationale. I did this image for this reason, and it sounds medically reasonable. You're free and clear as long as you can justify what you just ordered. If it turns out that it should have been something different, you had a good rationale and you follow good clinical reasoning. They're not going to censor you for that. They're not going to discipline you for that.
But thank you for bringing that up, Catherine, because that basically illustrates a point. This is the stuff we get afraid of, and this is what stands in our way. This is a real, this fear is unsubstantiated. I don't know where our recent grads learned this, or our old grads learned this, and frankly, this isn't how the real world plays out. No one's going to come after you, knock down the doors, and there won't be any black helicopters. This is really, this is not how the world works. And God knows how many imaging studies are inappropriately
Right.
or just mistakes. Everybody's allowed making mistakes. And what's the worst that's going to happen? You ruled something out. Big whoop. If a physician actually doesn't get the right diagnosis, you know what happens to them? We just make a diagnosis. It doesn't matter. So we have to lose this. We love to catastrophize. I used to be a great catastrophizer, Catherine, but it's just not how the real world plays out. Linda, you got a question?
I do appreciate this talk. Have you ever ran into an instance where you felt like the x-ray wasn't a good x-ray or a good place to refer? Because sometimes there's a talk like urgent care doesn't have as good as machines as maybe a direct imaging center. Or I've received a patient that I was like, I think you have a radial head fracture. They said, no, it was at urgent care and it was negative, but they ended up going to a specialist with better x-ray machines and it was positive. So I didn't know if there was an opinion on where you send them.
There is. Just like there's different quality of PTs in the world, there's different quality of radiology centers, and there's different quality of machines depending on the picture you want to take. If you're worried about artifact from metal, they've got MRIs now that you can take over a total joint and you get a lovely picture out of it. You're right, urgent cares tend to not be the most, at least the ones we have here, they're not the best images. So I avoid them unless I absolutely have to use them. Depending on what modality I'm using, I do have favorites in centers I will send to. And if I get an x-ray and I don't like the quality of it, I will order another one myself from a different place. There is no harm in that. I'll be like, this x-ray does not render the data I need. I need to have another image, and I don't even think this was the right one. So I might ask for a different version of it, a different side view or a different angulation for it to rule in or rule out what I want. And sometimes there will be kickback. The insurance is like, but they said there was an x-ray. And I'm like, yeah, but it was bad. So it's not giving me the information I need for the patient's benefit. We need to redo this film. And they're okay with it if you could justify the reason. Surgeons do it all the time. They always have their, oh, I want my MRI done with a hat on or something. They always have something weird they really need to do their particular image. And it gives them a hard time. They're like, okay, if that's what you really need to see, what you need to see, we'll do another one. And same thing, if I get a bad image, I called back on the one and I was like, this looks like there's something wrong. And they're like, no, that's just artifact. And we had a discussion of how and why. So it's just feel free to challenge it and question it. If it's not what you need, order what you do need, what's best for that patient.
Plus, sometimes a stress fracture will take some time to surface, so you might have to order it again anyways. Sandra Kaplan has a question for you, Scott.
Hi, thanks. This was a great presentation.
Oh, thank you.
I am struggling with where the line is for what the expectation is for an entry-level graduate of a DPT program in terms of
Okay.
level of skill and confidence versus, what might be expected for postgraduate training.
So in terms of like residence or residency or fellowship?
Yeah,
Okay.
because, we're teaching at the DPT level and we want our graduates to come out with this some level of confidence and belief
Sure.
that this is part of their practice. But the content, we're limited by how much time they can spend with us. And not
Right.
every student can do a residency following their graduation, nor are they always in a place to do that. So where do you draw the line on what the competencies are that we should really be aiming at the entry level versus what really requires some practice skill or that advanced training that residencies and fellowships give you? Is referral for imaging something that should be reserved for people who have done a residency or have their, specialist exam certifications?
I'd like to tack on a little bit of that question too. Sandra, I am so thankful you brought that up. That is so important.
Great question.
Scott, did you need a residency to do image ordering? And by the way, do you know of any other profession who now has imaging privileges that have the same amount of musculoskeletal background as us that are still imaging? In other words, you know where I'm going with this, Sandra. But go ahead, Scott.
No, we by the time a DPT graduates, our understanding of musculoskeletal function exceeds that of all the rest of the professions, as far as I can tell. We are already more uniquely positioned to be doing this right than anyone else. I did not go through a residency, and I didn't learn my imaging in the fellowship. I do, however, teach imaging for a residency and a fellowship now. It was just you figure out what to order over time. By the time you graduate, you should be good for the vast majority. There are going to be weird things you find later in life and later in your career as you become more and more proficient as a clinician. I wouldn't expect a first-year clinician to do manual skills as good as a 10-year clinician that does them. So just like every other skill set we have, the baseline should be, can you order an image that doesn't compromise the patient? And is it appropriate to rule out anything deleterious? I think teaching at the DPT level is absolutely a fantastic idea, and you should be able to come out of that DPT program ordering right away. There's no need to have to go through an OCS or to go through a fellowship program. It should be day one. Use those collaborations with the residency or with the imaging centers. I know here at Regis and at CU, they will send people to the imaging centers. They have little micro field trips, and they have imaging people come to the campus, and they work with them very closely to make sure it's done well.
The one thing
I love that idea. Thanks.
I'll tag onto that, Scott, and saying that here's the thing. We study the DPT, doctors of physical therapy, nurse practitioners, PAs, have imaging privileges recognized by Medicare. They don't have our training. There's not even a mandate for radiology of any sort. And here we go. We're very good at kind of being self-effacing and always looking to be even more prepared. I condone. I think it's great that we're so focused on always improving, but we have to watch out. At some point, we have to say, you're doctors of physical therapy, you're out of school, you've learned how to learn. Now go just do and be an expert, because you're already musculoskeletal experts better than any other allied profession out there. So I think we have to watch out when we finally say, you're birds, spread your wings, do it responsibility. You've taught good students, so that's just, Shirish, I know you've been having your hand up and being patient there. Go ahead, you're on mute.
Thank you, Scott, for that presentation. I had a comment and a question. The comment was to tag along on the point of developing relationships with the radiologists. So I had a case 2 days ago where the MRI was ordered by a PA, and the MRI had findings which were inconsistent with the patient's history. So I picked up the phone, called the radiologist, even though that was not my name on the radiology report of the referring doctor. The radiologist was very polite, welcoming, took the information, and I'll mention a little bit, the report said the patient had findings related to the surgical procedure done. Whereas when I looked at the image, which actually showed a large fracture in the calcaneum bone.
Mm.
Like, patient never had a surgery done, and this looks like a full-blown fracture. So I still called in, and I, just politely shared those findings, and the radiologist was like, yeah, okay, if the patient didn't have surgery, it's definitely a fracture.
There you go.
And he was like, I'll write an addendum to this and we'll send you the report. So that was, really nice to see that kind of a relationship with them. So I would say one important thing is whosoever writes the imaging form should fill in a little bit of history on the patient and what they're expecting, so that the radiologist can tag on appropriately on that.
Yes. And that's one of the reasons they really enjoy when we order, because we tend to give them the information, the suspicions, and what's going on. It's much easier for them to know what to look for if we kind of give them an idea of what we want. And they're better. It's better than an ankle 3 view.
Exactly. Yes.
What's wrong with the ankle?
So Scott, is that a typical thing that makes us unique in the way we prescribe for X-ray? We tend, or rather radiology, do we tend to include mechanism of injury in more detail than other disciplines, do you think?
My understanding is yes. We always have a large area. If anything, I run out of room on there to write down everything I want to say, because I want to make sure they have all the info they need to get the job done. And
Sounds like a physical therapist.
yeah, I want to make sure it gets done and gets done right. So I tell them, this is what I'm thinking. So if I'm off track, please, give me a better picture than what the one I'm asking for. It's my understanding we tend to ask that pretty clearly, and that tends to help out quite a bit.
Yes.
Just want to put a point forward. Shirish practices muscus, so does Cindy Bailey. She's still around. I know we were all kind of we were thinking when you were going over that avulsion fracture on the pelvis, we were all thinking like, just do ultrasound on it because it picks it up instantaneously. We're actually screening abdominal aorta as well.
Oh, nice.
So easy. It's like a joke. I'm just wondering if you guys have adopted this in your practice. I just feel like it's an inevitability for you.
I'm starting to look into going down that road now. It's showing up more and more often than I'm needing to do it. So it's getting to the point I'm going to go ahead and bite the bullet and do it. I haven't in the past, just because I haven't had enough patients to need it. And I do understand that ultrasonography, it's one of the few modalities that is hugely dependent on the skill set of the person using it.
Sure.
And if I wasn't going to be using it often enough, I was concerned my skill set would not be appropriate enough to catch the deleterious stuff. So I've continued to refer that out at this time, but I'm probably going to start pulling that in and start seeking that certification.
I think you'd be great.
Okay.
Curious, you got a question?
There was a question. It is off imaging. You'd mentioned in your presentation that you're also doing labs. How is the feedback on sending labs to different corporations for patients?
As long as you have a medical license, a PT license, I've ordered from LabCorp. I've ordered from Invitae for genetic testing.
Wow.
Never had any pushback for it. Part of the forward momentum on that was Colorado has a lot of functional medicine practitioners right now. And they're typically licensed in a different discipline, since functional medicine doesn't have its own license. So in order for them to be able to order imaging, they've done a lot of the footwork ahead of time to get labs to accept their orders, because they have a license, and that brought in all the PTs along with it, all the chiros and everybody else.
Wow.
So, And
Nice.
if they call back and they have a problem, I pull out my practice act. I'm like, anything I can't test for, I have to refer. So I'm referring. And they
That's-
generally are fine with it.
That's
Scott,
all.
Scott, do you order DEXA for osteoporosis scans? Do you sometimes do it because you're concerned about any sort of manual technique you'll do with the patient, or how do you use DEXA?
I've used DEXA scans for, we again, we get a lot of chronic pain. So sometimes with CRIPS, you get some osteoporosis or some osteopenia creeping in. And especially when you get the patients that are, some of the chronic pain will be more malnourished. I'm suspecting low bone density. Many of them are lower socioeconomic. They've not had any workups. I'll pull that in advance because no one wants to do a manipulation that results in a wheelchair. And if I think they can benefit from the technique, and I need to know where their status is. I mean, how big of a fall risk are they? Are they going to be damaged? I'll pull that as a baseline, and then I'll start also giving them exercises. And in Colorado, I'll give them nutrition advice as well for how to start improving their bone density. Because we don't have a practice act for nutritionists in the state of Colorado. So that also falls under the auspices of a physical therapist. We're allowed to make those devices and those discussions.
Great. Well, I think we're, unless there's another question, I'm going to wrap it up here. We still got 15 stragglers. I am deeply this was amazing.
Thank you. I hope it was helpful.
I'm over the moon on this, frankly. I just want to thank you and Research Chair George Bennick. I want to thank participation. Thank you so much for great questions. Sandra Kaplan, Aaron Kyle, Shiri Sachdeva, always a pleasure having you aboard. Thanks so much. This will be posted. We're next month, we're going to have a really good thing. Sandra, I think you're going to like it a lot. It's Chuck Hazel and Bill Boysenald are going to release a first look on information from their nationwide survey on where imaging academics is going. So I think that's going to be really interesting for you as well. So people, thank you so much. And once again, Scott, unbelievable. I really appreciate it. I'm going to watch this thing over and over again, I'm sure. There's so much in there to digest. So thanks, everyone. Have a safe weekend and a great Thanksgiving.
All right. Have a good night, everyone.